It's almost like the person was experiencing distress in a different way that was very understandable from a psychiatric perspective, but wasn't exactly the kind of combinations of symptoms and attributions that are explained in the manual. And you have to do this translation process that the DSM-5 now helps clinicians try to manage. There are several ways in which these culture-related changes in DSM-5 can affect the daily work that providers carry out. One important way has to do with cultural assessment. The cultural formulation interview, which is this operationalized way of conducting a cultural assessment, I hope becomes very widespread, and clinicians use it to figure out what patients' perspectives are, what their families' perspectives are, what they expect from care, what their concerns about care are, and so on, so that they can get a better sense of what the patient and his or her family and social network are thinking about, so that they can negotiate treatment better, explain their approach for diagnosis better, and so on. So that's something we have high hopes for. Another part of the manual that I hope will be useful is these changes in the criteria and the text that describe for clinicians a kind of more inclusive way of doing an assessment of a particular disorder, so that if the disorder presents in a way that's not exactly like DSM-4, the new changes in DSM-5 explain just how the disorder can vary so that it still can be diagnosed as the disorder that we all know from DSM-4. So that, for example, with social anxiety disorder, if there's a more of a concern about offending others rather than being humiliated, this doesn't throw the clinician off so much that they don't see that the rest of the presentation is just like social anxiety disorder, and therefore this new change is a way of increasing the sensitivity of the diagnosis so that people can pick up different presentations. And in addition, I'm hoping that the explanation of how cultural concepts of distress and psychiatric diagnoses fit together, what their relationship is, might help in general overcome some of the misdiagnosis and the confusion that may happen when disorders present in a way that is different, or the patient experiences symptoms from disorders that in DSM-4 are considered separate, and yet they're experiencing them together as one presentation, that somehow the clinician doesn't get completely confused by this new way of putting the disorders together, if you will, or diagnose with 10 disorders, or get very confused about whether it's one disorder or another, but rather this hopefully explains just how much diversity there is in presentation and what's a good way to think about the relationship between these culturally specific ways of describing disorder and distress that are not currently in the manual, and how to sort of crosswalk those presentations with the diagnoses that are in the manual. The task force from DSM-5, which is the executive leadership group of DSM-5, put together what they call the study group, which is a study group that cuts across, the different work groups and task force in terms of key cross-cutting areas in DSM-5. And the purpose of the Cross-Cultural Issues Subgroup was to tackle the areas in DSM-5 that needed some information on culture, cultural variation in symptomatology, in prevalence, in risk factors, in course, any number of topics that cut across a disorder or set of disorders. The Cross-Cultural Issues Subgroup prepared, along with the experts in those areas, prepared material for DSM-5, and also developed material that was useful for the diagnostic process as a whole, such as a cultural assessment and other areas that I will describe in this interview. One of the functions of the Cross-Cultural Issues Subgroup was to work with the work groups for particular disorders and identify topics that had a cultural focus and should be clarified from DSM-4 to DSM-5. And these could take many shapes. One was, for example, the issue of whether the same criteria for a disorder applied across all cultural groups. And what we did there was to do a literature review of work on culture and phenomenology, presentation, experience of disorders, symptoms, and see where the points of variation were. And there were several disorders where we found that the existing criteria in some ways didn't incorporate all the ways around the world in which that particular type of disorder could be expressed. So take the example of social anxiety disorder. Social anxiety disorder is quite prevalent around the world, but the prevalence changes a fair amount. In fact, contrary to the idea that disorders have the same prevalence everywhere, psychiatric disorders have the same prevalence everywhere, in fact, studies that have been done epidemiologically using the same instrument around the world with the same time frame of 12 months, trained in the same way, that the people administering are trained in the same way, discover that the prevalence, 12-month prevalence of social anxiety disorder can vary 34-fold from 0.2% in parts of Asia, for example, to 6.8% in the United States. So it's a tremendous variation in prevalence. It's always not an extremely common disorder. It's less than, it's at most 6.8%, but still, that's quite prevalent and very different from 0.2%. And so the range of prevalence was important and to point out in DSM-5. And in addition, there's also the issue that in certain experiences, certain places, social anxiety disorder is experienced a fair amount as as acting in a way that would embarrass another person, might offend the other person, like Japan and Korea are kind of famous for this idea. The notion of taijin kyofusho in Japanese, my Japanese is terrible, but at least taijin kyofusho, that the concern is that you might offend rather than that you yourself be embarrassed. And when this is studied, it's discovered that a fair number of people in Japan, Korea, and so on are both concerned about offending and concerned about being embarrassed. And the same is true in many other parts of the world, Australia, the US, where people are both afraid of being embarrassed or humiliated and sometimes afraid of offending. So it's a bit of, it's true that certain prevalences tend to be most common, certain ways of experiencing it tend to be more common in certain places, but they're not exclusive to those places. It might have to do with what one first presents with or to a clinician, or what is most salient to that group. For example, for individualistic Westerners, it might be more salient to speak and be first concerned about humiliation yourself, but it's not, it's also true that you might be concerned about offending others in some sense secondarily. And perhaps in other parts of the world, it's the other way around, where you present, you say that you're concerned about offending others. That's very true, but it doesn't deny the fact that you might also be concerned about being humiliated. So it's maybe a matter of emphasis. And one of the things we did was to include in the criteria both types of fears. So you can be feared about humiliation or embarrassment. You can be afraid of that, but you can also be afraid of offending others or being rejected by others. And both of those are now included in DSM-5 as part of the criteria of fear of negative evaluation, as opposed to DSM-4, which only mentioned humiliation or embarrassment as an example of fear of negative evaluation. So it's a way of expanding the criteria so that more ways of being socially anxious are included. Panic attacks are also quite human, quite prevalent around the world, but they can take different forms. And the work of my colleague Devon Hinton in Cambodia, for example, shows that panic attacks among Cambodians is associated with certain symptoms that are important, salient in terms of Cambodian understandings of how the body works and how anxiety expresses, and that may be connected to the unbalanced flow of Khyal in the body, a wind-like substance, if you will, that is thought to be or experienced as being out of balance with anxiety disorders and other disorders. So because of this type of presentation involving this substance, people may have different symptoms like headache or neck pain or tinnitus, different symptoms that may be associated with the anxiety of a panic attack that are not so common necessarily in other parts of the world. So there, what we did to make sure that presentations that may be slightly different from what was described in DSM-4, to make sure that those presentations are not missed, we included a note to the criteria saying how these other symptoms could also be present in panic attack and should not, if you will, confuse a clinician when they present to think that it's not panic attack in that case that they're seeing, as long as the person also fulfills all the other symptoms of panic attack that are in the manual. An issue that was very important to the cross-cultural issues subgroup in terms of the role of culture in DSM-5 had to do with describing better how a clinician could conduct a cultural assessment as part of a regular mental health interview. And DSM-4 had a narrative description of what should be included in such a cultural assessment, and that's called the Outline for Cultural Formulation that appeared in Appendix I of DSM-4. But we wanted to take that narrative description and include with it a set of questions, a more operationalized questionnaire, set of questionnaires really, that clinicians could use in terms of assessing for culture in a clinical interview that would kind of orient, guide clinicians who may not be so sure how to apply the narrative description in real time. We wanted to give them a set of examples and instructions, guidelines more about how they might do it. And so we developed this set of questionnaires. There's three kinds. One is a general core questionnaire, a basic assessment that can be used with any patient in any setting by any clinician. So it's not meant for minorities or underserved populations alone. It's meant for any cultural group, and we all have culture, if you will, of one kind or another. And so they can be used with any patient to find out how they understand the illness, what's the priority for them, what does their social network think is going on, what are their preferences for care, what have they done in the past that has helped or not helped, what is it in their context and environment that helps, that doesn't help their illness. So all these things are part of a basic assessment, 16 items in Section 3 of DSM-5. And in addition, we had two other sets of questionnaires that could be useful. One is an equivalent sort of basic questionnaire, but for informants, that can either be used for collateral information, if you wanted to, in addition to interviewing the patient, you wanted to know more information, or sometimes if the patient is unable to help you with the interview at that time, if they're very, very young or if they're demented, any number of these possible uses, you could use the informant CFI, we call it cultural formulation interview. Or in addition, the third set of questions has to do with more supplementary in-depth modules that take the parts of the basic assessment and ask more questions about them. So there's a set of questions on cultural identity and on explanatory models and on any number of other sort of aspects of the interview that could be done in more depth, as well as modules for specific populations such as children or elderly or immigrants and refugees and caregivers also. Those are the extra modules that you can use, and if you can flexibly use all or some of these questions and questionnaires to help carry out a regular assessment in a way that is sensitive to cultural factors. One other aspect of what the cross-cultural issues subgroup wanted to do was explain briefly but clearly what we felt the relationship is between what are called the culture-bound syndromes and the psychiatric diagnoses in the rest of DSM-5. And we did that in two ways. One is to have a description in Section 3, in the new section on assessments. In Section 3, we had a general description that talked about this relationship, how to think of the relationship between what we now call cultural concepts of distress, as opposed to culture-bound syndromes, cultural concepts of distress and the psychiatric diagnoses. So first we describe how to think about their relationship. And then in the glossary, in the appendix, we have a glossary that lists 9 examples of different cultural concepts of distress and helps the clinician walk through how to think of them. So we give the data on their description, sometimes their prevalence, and specifically what research has shown over the last 20 to 30 years is the relationship between these cultural concepts and psychiatric diagnoses. So take, for example, Ataques de Nervios, which is a condition that I study, other people study, which is a fit of emotionality that people can have, common in Latin America, but elsewhere too, but that people can have in response usually to adversity. And it is often characterized by a sense of being completely out of control. It can be highly dissociative, highly disruptive. 1 out of every 7 first ataques de nervios are associated with a suicidal attempt. So it's a very strong loss of control emotional reaction. And this type of presentation can be quite confusing to clinicians. It might seem like seizures to some, or panic attacks to others, or intermittent explosive disorder to others, any number. So what we did was describe what ataques are and explain that this kind of pathology, this kind of way of experiencing distress can be very pathological and difficult, and it can be diagnosed in multiple ways depending on the characteristics of the individual attack. So it's not a one-to-one relationship with only one disorder, but rather it's a way of being distressed that can cut across disorders from a psychiatric perspective. And the issue for the clinician is to figure out this particular instance of ataque. Is it like panic attack? Is it like intermittent explosive disorder? Is it like a dissociative disorder? What is it? How do you do a translation from this particular set of episodes to the psychiatric diagnosis? It's almost like the person was experiencing distress in a different way that was very understandable from a psychiatric perspective, but wasn't exactly the kind of combinations of symptoms and attributions that are explained in the manual. And you have to do this translation process that the DSM-5 now helps clinicians try to manage. If you're a trainee and you're looking at this video, there are several areas of cultural psychiatry that are very exciting at the moment and that you might find interesting. One of them has to do with how a cultural psychiatry approach can really inform the priority of establishing a good communication with patients and tailoring what we offer patients in treatment and how the treatment is delivered to their ideas and concerns and expectations of care. And one of the ways to do that involves the cultural formulation interview, which is a way of assessing for culture in a clinical situation, and in particular what the patient's understandings are and expectations, and their social networks, expectations and understandings. So communication and engagement of patients and clinicians through a better sense of understanding each other is a key area in cultural psychiatry. Another area has to do with what is the best way policy-wise, treatment-wise, public health-wise of reducing the disparities that currently exist in the health of underserved population groups, such as cultural groups of one kind or another, and also in the care and the mental health services delivered to different underserved groups. So anything that has to do with disparities reduction at all those levels is of great importance at the time. Related to that is the general issue of global mental health. What is the best way to deliver mental health services in low resource areas? What's the best way to learn from low resource areas in high resource areas so that we actually can implement very effective and disseminatable approaches in developed countries, as well as improving the care in developing countries, how to shift tasks between a general health system and a mental health system. These are all important areas, while at the same time being honest to the changes, to the ways in which people in different countries understand and expect the care to be delivered, and understand and expect the way they express illness. So it's not to just import models from the West to the rest, as they say, but rather to actually take seriously what people in the rest of the world are actually, how they experience psychopathology and how they understand the problem needs to be treated. That's the third area. The fourth area that I think might be very interesting to trainees has to do with the training of cultural psychiatry itself. And it would be a great role for trainees to get involved in thinking about the best ways to train other trainees in cultural psychiatry. And we're now exploring the best ways to train in cultural psychiatry, and there are different approaches for how to do it. ADPERT, the residency trainers organization, has a set of model curricula that have been chosen, and in general the Canadian Psychiatric Association has a set of guidelines for the best ways to teach cultural psychiatry. So in general there's a movement afoot to find a good way to teach cultural psychiatry, and it would be a perfect venue for trainees, residents, other interns, people to get involved in terms of how to do that in the best way.